anybody know there is more than casinos in Las Vegas? Well, I have a surprise for you. There is a dental school there. And our dental school is a young one. It's only 20 years old. And we just got a brand new dean, Dr. Ma. He's interim back in, he just started in September. And I basically, the only geriatric dentist they have. I am a geriatric dentist. I don't know if you know what that means, but in a nutshell, we don't do complex dentistry, but we do dentistry on very complex individuals. Very sick. My patients are all in nursing homes, they're in hospitals, and they're in hospices, or they are homebound. They are very, very sick people that oral health is kind of forgotten. That part of the body doesn't usually come in count. So I chose this topic because I'm an educator, I'm a clinician, and COVID taught our dentist students to be licensed dentists without touching a patient. Isn't that amazing? And our educator learned how to teach dentistry, which is heavily practical and clinical, without sharing a patient's actual mouth. So with the condition we were in, this actually fits to kind of bring in a whole new aspect into the healthcare. Dentistry is not outside the healthcare. To see that we are dealing with a population that come to us with their fabric is not like pediatrics. They don't come in with a clean white fabric. They come in with a whole life experience, that their life experience has definitely impacted her health, including oral health. So being able to train or be a dentist that actually can be sensitive to those cultures, because nowadays, in the past at least 20 years, in any country, especially in the States, there are more older adults population with foreign background that they are actually born in this state. And being able to recognize that and work with that is a whole knowledge on its own. So the difference is person-focused and patient-focused. What it means, can anybody cast any concept of what does that mean? How do we categorize our patients person-focused or patient-focused? Anything is, there's no wrong answer. Can anybody tell me anything you can think of? Don't go all at once, one at a time. Then just the disease, correct. And you're not even a dentist. Thank you. That's all it means. When we talk about patient focus, we're concentrating on a disease, on the condition. When you look at a person focus, you look at the person with the disease, not the condition in the person. It's a whole different dynamic. It resets the whole thought process and a treatment plan when you look at it that way. And here is age-friendly health system structure. The whole structure is based on 4 M's. 4 M's, which stands for matters, medication, mentation, and mobility. Basically, in any older adults that you look at, they function on those 4 pillars. What is it? Let's put it this way. In older adults population, and that, by the way, considers 65 and older, not 50, not 55, not 75. 65 is an age 65 and older considers geriatric population. these populations are the expert to tell us what they want. This is what I want. We don't tell them what's good for them. They tell us what they want, because back to what we talked about, they really need, they come from a culture and a life history that what matters to them is what they are going to give you the availability to work with. And we are the expert of giving them what they want. We're not the expert of telling them what's good for them. Please change that mindset. The doctors, it doesn't mean I know better, I'll tell you what you need. Not for this population. They know what they want. They're smart enough, most of them, if they don't have dementia. They have life values. For some people, going to the church, to the mosque, or hang around their friends, play cards, staying home doing nothing, there is all what they want to do dictates, it's the umbrella, dictates how the rest of things is going to fall in place. If you know what they want and you really listen to them about what they want, the rest of these, and according, it's negotiable. And if you negotiate with them for what they want, they actually hear us. They don't look at you, nod the head, and have head totally somewhere else. And that can happen. They kind of, especially when they are dealing with a younger practitioners, in their mind, in some cultures, age brings wisdom. Who are you to tell me what I need to do? And that's very valid. The reality is their reality, not our reality. So when you talk to a patient that is on polypharmacy, how many medication costs polypharmacy? Anyone? What is polypharmacy? Multiple medications, correct? And how many medications cause polypharmacy? 5 and above. Anybody on 5 meds and above, over the counter or prescriptions, or even culturally herbal meds, teas, powders, whatever it is. Having to know all those, mentation, are they starting having any kind of forgetfulness? Are they taking those meds in time properly, proper dose? Is anybody there to help them? Is anybody pointing? In majority of these individuals, their medication in their mind is the yellow one, white one, pink one, blue one. Okay? So they don't know exactly which one is blood pressure medication, which one is COPD medication, which one is... to be able to bring all that into this plan, it's a science of its own, and it's age-friendly health system. And who's messing up with my slide? And it comes to mobility. Mobility is not just movement, although that's a big part of it. Being able to drive to the appointment, being able to keep the appointment, what time of a day the appointment is. Are they going to be, is it a rainy day? Is it dark day? Can they drive properly? Is the eyes in the right? Can they afford it? They are all fall under the umbrella of mobility. That's why a lot of older adults no-show in appointments, and we don't even recognize that as an issue. They forgot. They might, but there might be a lot of other things. If they depend on somebody else to bring them to the appointment. So this whole ordeal, being age-friendly health system based on the 4 M's, was born in 2019. It's very, very new healthcare delivery system. And they have invested millions and millions of dollars in funding, which I happen to get one of them, not millions, but in total there have been a lot of fundings in the US and worldwide to be able to bring the older adults, 65 and older, into a healthcare system that is friendly with their needs. Not anybody at any age, healthcare system it's not healthcare as we all know, although it's a global issue, but there is definitely not one size fit all. If we have pediatrics, we need geriatrics, and a lot of people fall in between, and a lot of others that come into the play if we are expecting actually to have a positive clinical outcome. It's not how many patients we see or how many patients during a day, but when you measure the quality of care is measuring the outcome, clinical outcome. And the clinical outcomes for older adults based on this technique has been the highest because we work with them. We don't work and expect them. It's a very different concept. So let me see if I'm going to go to the next or I am not. Can you advance this for me, please? This is very temperamental advancer. Great. So this is what we started out with patient-centeredness. When your patient comes in, what do you ask? What's the matter? Whereas, what matters? There is a big difference between what's the matter and what matters. When you look at it on that fundamental base, then you start, basically it just changes the whole vision of how we see our patients. And then in a patient-centeredness, each visit we want to do whatever we're supposed to do. Whereas in a person-centeredness, there is a lot of other elements come into the play. It's not just look and open your mouth, let me see. Before you even get to somebody's open your mouth, which is I know most of you as a dentist especially, we don't see it that way because it's become a job, but mouth is a very private organ in a person's body, especially in older adults. When you put a patient all the way back, almost to the ground, in that vulnerable position, and you look over them and say, open your mouth, I'm sure you all have seen dentists, but as a dentist, we look at it in a whole different way than somebody that comes in, that it's a vulnerable position. Toothaches are not easy. A lot of people come, I don't know how many of you had the advanced hot toothache, but I heard, thank God I never had one of those, but I heard it compares to kidney stone. It's painful. So be able to address that properly with a proper clinical outcome quick. You need to know what that patient wants. What is its expectation? If patient wants the tooth out, don't convince them, oh no, we can do root canal and then we can do crown lengthening and then we put a crown on you and da-da-da-da-da-da-da. By the time we're done, the patient is looking at you, can you get this thing out? One of the worst things that we do is trying to talk to patients either medically or legally or properly when the patient is pain. When patient comes in with pain, and I mean pain, numb them before you talk to them, before you decide what you want to do. Nobody in pain is going to listen to what you have to say. They just say, are you done? Just get this done. So it's very important to be able to put ourselves in a position which is the only reality, the only realistic position. It's very easy to sit on the other side of the table and tell you, this is what you need to do. But when you put yourself on the same position that you can either understand the pain or stop the pain before we can talk to anybody. And how, even if the patient says, let's put it in a positive route. Yes, I want to save the tooth if we can. Is it a proper decision if patient is diabetic, has multiple other missing teeth, periodontics involved, there is medications involved, conditions involved that may not offer that ultimate outcome that we are looking for, that you may or may not see in somebody in their 30s and 40s, in somebody that is in 70s or 80s. And please don't let me keep talking. If you want to stop me or you have a question and you disagree, let me know, because I like kind of those conversations better than me just yapping around. And being able to have all those empathy, respect, it's a social trait and a skill that's kind of dying in certain countries and certain sections, especially in the West world. Elderly, older adults, by the way, elderly is a wrong term. We call elderly to people that are very, very sick, very fragile. 95, 99% of the time, they're called older adults. So medically, clinically, research-wise, you don't call older adults elderly. It's a wrong term. Your paper will get rejected. Being engaged with them, in their mind, what they want, in their culture, in their background. That's all being engagement. Make shared decision. You don't sit on the other side of a table and say, I'm the doctor, I tell you, you do. You share decisions. If you want somebody respond to what you have to say, you negotiate that. If the person is not cognitively inclined to be able to do that with their families. Whomever is the person, brings them in, and it's legally their representative. And coordinate care. What does that mean? If they cannot drive, make sure you coordinate with whomever brings them in. My patients usually, I either have to go to them with my little mobile set that I have, or if they're coming to them, I have to make sure that I talk to the facility they're in. Even the driver is part of that negotiation. Making sure this person is coming in time for what they need, and those appointments are usually very short. Very short. If they have a case with me, my staff already know what we need to have set up handy. They come in, they need to go. Because they usually, if they're on diuretic, if they're on blood pressure medications, they got to pee every 15 minutes. So you just work with them for what they can do, what they are able to do. You negotiate that care. I don't have a lot of slides. I only have 9, which I already went through 6 of them. I have 3 cases. They're all my patients. And I just wanted to bring this, not as a lecture, but I just share this with you and kind of get your idea about what would you do and how this situation could be actually prevented. This, his name was, I forgot his name. He was at the time 96, advanced Alzheimer's disease. He was homebound, he wasn't in a facility, and family decided to actually hire a full-time nurse in the house around the clock and not put him in a facility, which I personally thought that was a fantastic idea. I've been to enough facilities to know if they hear me, they'll kill me. I wouldn't put anybody there, not especially my parents or my loved ones. And it doesn't matter how much they charge. It's all bells and whistles of the lobby. When you go to those rooms, the ones take care of those, and what the real story is different. So he was home, and as you can see, he was a very, very successful businessman. I think he owned his own insurance company or something. He was 96. His wife told me he had, as you can see, he has this beautiful long span bridge, which was zirconia, that he had him done about 30 years ago at that point. So he was probably in his late 60s. Am I right, doing the simple math? So he was about in late 60s when he had a lot of apparently worn down teeth, a lot of attrition, a lot of erosion, And he was meeting people, insurance agents, so he gets these teeth done. As a result, when I got there, multiple teeth were non-vital. One of them, if I don't fall, I can show you. Right up there, you can see these, that radiolucency was a large one, and you can see that as a fistula in a tissue. So when we x-rayed it, in that bridge, there was 3 teeth involved. One was completely broken, caries basically disconnected the tooth from the bridge. The other one was extremely infected with a fistula, and the other one also had it on a distal side. So how did this happen? How did this happen? First step, go back to planning. The man was in his late 60s. A zirconia bridge is too hard of a material to use for a man that you don't know where the next 20, or even forget about 20, next 10 years is going to be. The treatment plan didn't fit. You don't put an 8-unit zirconia bridge without a maintenance, because the man at that age is not going to get any younger, it's going to get only older. The medications that cause dry mouth, this kind of beautiful work, they need a lot of maintenance. So somebody didn't think that where this 68, 69-year-old man is going to be in the next 10 years. The treatment plan didn't fit. And by the time they prepped all those teeth, already eroded teeth, already coronal crowns diminished by at least 25, 30%. You prep that furthermore. You put such a material on that, as I was cutting zirconia. I don't know if you have ever cut zirconia. As I was cutting zirconia with a mobile unit, I was cursing the sun and the moon. But it had to come out, and 8 units. So we had to remove that. And then he had stopped, obviously, at some point, brushing teeth. The care wasn't there enough. So and the dry mouth that was happening for years. So as a result, he really didn't get benefit from that beautiful work. And the dentist who did it did not see his or her own failure, because they're not there at that point. They don't go to the office anymore. These are the people that are forgotten. Nobody sees them. When you treatment plan, make sure you know it to the end, because most of you, when these things fail, you won't see it. So what we ended up actually doing, removing all that, and he was too old and very, very sick to put any kind of removable there, because removables, patients have to learn, Myofacial needs to learn how to keep him in, how to take him out, how to put him in. So removable at that point is not an option. So what do? I basically took that out, cleaned whatever I needed to clean, and made him a temporary material acrylic bridge. He was only eating soft food anyway. I made acrylic, like a temporary bridge, put it in, just making him functional and off the pain. That's it. There is nothing else involved. We weren't talking implants, we weren't talking reconstruction, we weren't talking anything. Just get him off the pain and make him functional. And that's all it was. And my next case is this one. I was looking at the program. Somebody is going to talk about the material of the bar, and I can't wait till I hear that. And this lady apparently had a all-on-4 on a maxilla with a bar. By the time she went to the nursing home, again, she was in her late 80s. By the time she went to the nursing home, she was about year and a half in. Apparently, the denture fractured. The denture fractured. When I was called in, the bar was missing. I saw those x-rays actually on her records. So the bar is not there. She has no occlusion, even though she has some teeth on the bottom and a little bit of that piece of denture is still left there, there is nothing for her to close down. And when she closes down, those posts are actually into her lower gum. She is hurting, and all they've been doing for the past 2 years, she was put on liquid diet because she couldn't eat. She couldn't chew. Did anybody with that plan serve this woman properly? Heck no. First of all, you never do all on 4 on maxilla. I don't care what the research says. The reality, research has a funder, every funder has an agenda. That's the Bible in my head. You can only count on those numbers if they actually apply to the reality. And I've seen so much of these failures. I'd rather give somebody just plain old denture than putting it all on 4. Put it all on 6. And don't put bars. 6 is very good enough to have attachments loaded, and you can put the denture in safely and nothing will happen. They don't need bars. They do not do 4 on 4 on a maxilla. Lower is fine, not on the maxilla. So anyway, this lady truly suffered. And the fact is that you can't take these people sometimes. She was in a memory care. You can't take them out of memory care. So whatever I have to do in that facility with what she's available to do, it's a whole different world of dentistry that you don't have to do it, but you gotta know about it. This was another one. I'm going to talk 2 minutes, and then I have about 5 minutes for some questions. This man was in memory care again. I don't know how many of you have seen or know about those partial dentures with a gate. And they actually have a lock in one side, and then you have to open that gate, unlock that little thing, and remove the partial. It's a very sophisticated at its own time. They don't make those anymore. But somebody needs to be totally mechanically together to be able to remove this. Apparently, nobody knew he had this partial, including his household. Because when they brought him in, he was already at home with dementia for 3 years, and then family brought him in because they couldn't take care of him anymore. And then, so my calculation said that partial was in his mouth for a good 5 years without ever being removed or cleaned. The tissue was overgrown. I mean, it was so heartbreaking to even see it. There was tissue all overgrown here. There was a tooth totally broken here, tissue over it. There is a prong there that obviously was sitting right into the tissue. I had to numb the whole lower arch, and numbing these patients is not easy. Numb the whole lower arch to just be able to remove these things from within a tissue and the receded gums on the root surfaces. It was a very, very, very sad and heartbreaking condition. When you make partial dentures, all I'm trying to say is, at certain point, when you treat having in mind where this person is going to be within the next 10 years. They may or may not have dementia as the time they see you, or maybe they have it, but it's undiagnosed. It's still very mild, because Alzheimer's cognitively has 7 steps. Up to stage 4, it's not clinical, nobody knows. Doctors can easily miss it. It's the stage 5 and above, they start showing symptoms. So, I'm done. Does anybody have any questions? Does the concept, yes, sir. I definitely would not make zirconia bridge. I would make PFM because he was still working. He wanted the static, but also maintaining PFM and removing PFM is very different than zirconia. And also PFM, at least, you know, when he was there 30 years ago, now it's changed. 30 years ago, the amount you had to reduce the tooth for PFM was a lot less than what you had to do for zirconia. So you choosing your material, it all comes into play that how would you do that to give him the same result but less chance of failure? That's a good question. Yes? Thank you for asking that question, because I sometimes I don't know how I did it. Uh-huh. The reason is there is not enough retention. When you put, because usually if you have 4, you have to put a bar for retention. Bar is not a retentive subconstruction for a long period of time. It's good for maybe 10 years, maybe, if the patient is cooperative, and usually the dentist says come every 6 months or every year. They can unscrew it, they take it out, they kind of check it, because that's part of monitoring the case. When you lose monitoring the case and you lose the patient due to other conditions, that's the time. It's like sitting on a ticking bomb that can explode any time, and you may not be around. And that's what exactly happened. So I rather, if somebody can afford 4 implants, I promise you they can afford 6. And if you make put the 6 implants and put the attachments, there's something like the old ERA attachments. You put those attachments in and make them nice and tight into the dentures. They are a lot more long-lasting and require less maintenance than having the bar, messing with the screws, this and that and the other. And the chance of fracture is 90% higher. So don't do 4, don't make bars. I mean, every case has possibly, it may not follow, but when you know something 80% has a chance of failure, don't do it. If there is a clot and there is 80% chance of rain, you take your umbrella. You may or may not use it. It's just a smart decision making. And then how I did that, I actually cut those poles. They even didn't look like abutments to me. I don't know what they were. Maybe they were temporaries. I don't know what they were. But I had to cut them, cut out and bring them actually at the point of a gum tissue or as a point of a fixture. And then I made a regular denture, but I used those little abutments to give it a little bit more. I opened up housing into the denture, and I put soft material in there. So the caregivers were able easily to take it out and put it in. Sadly, I went back 2 months later to check on her. The denture was lost. So she was, after everything we did, she was back on liquid diet. There's a lot of heartbreaking things you see. But at least she wasn't, every time she closed her mouth, she wasn't hurting herself, and it was just sad. It was a sad situation. Any other questions? Oh, I'm sorry. Yes. There is something in medicine we call about ethical decisions. And if my child at the age of 2 is going to run through this street and get hit by a car and there is no way around it, I don't take him outside. Or I maybe give him a little, what they need to step back. I'm not saying that's what you need to do to your patients, but you have to know at some point, if the perio is not good, they want a static, and you know you're letting them stepping into that fire. Ethically, I would say, I can't do this. And I've been a dentist for 35 years. I have said that to 2 of my patients. You know what, I can't do it. What you need is over. I have no pride to say to somebody, what you need is over my head, I can't do it. Go see somebody else. I had one case, a 40-year-old woman wanted all her teeth out, and she wanted dentures because they looked prettier. And no matter what I said to convince her that we can do this without taking her teeth out, she says, no, that's what I'm here. I said, well, I can't do it. And I had another case. 2, but you do what you can do, but yet at the end of the day, you have to be able to live with yourself that you did the right thing. But most of the time, if you include the 4Ms and you share their knowledge and you share the treatment, they usually say, okay, they compromise halfway. I can guarantee you I've seen enough of them. Any other question? It's been a pleasure. Thank you.